So I'm doing a case report on a case of treatment-induced neuropathy of diabetes. And the reason I chose to present on this is it was one of the most impactful cases that I took care of as an intern in family medicine. And I am an extremely good sleeper. It's never been a problem for me falling asleep, especially after a hard day at work. But when I was taking care of this patient in the hospital, I would come home and I just could not quit thinking about him, and I couldn't sleep. And thankfully, my senior, very astute medical resident that was 2 years ahead of me couldn't sleep as well. And her, instead of worrying about this, actually helped make the diagnosis and helped this patient with the trajectory of his disease. The other reason I wanted to present is this patient and his family were very interested in getting this information out there. This is a rare condition and a very disabling, terrible condition. And he just thought as many providers that know about this, the better. We as family medicine doctors take care of a large proportion of the patients with diabetes in this country. So we're in a good place to have this on our differential and be thinking about this. And potentially it could be practice changing. And I will let you guys decide after you hear about it. So DM is an 18-year-old who presents to his primary care doctor with some lower extremity edema. It's not very significant. In fact, the PCP noted on exam that he didn't think there was any edema. But being a good PCP, he listened to the patient and got a urinalysis as part of the workup. Urinalysis showed lots of glucose in the urine, lots of ketones, no protein. And on further questioning, the patient says, actually, for a couple of years, I've had some polydipsia, polyuria, polyphagia, and have had real trouble gaining weight. I've been trying to lift weights and eat a lot of food, and it just is not staying on me. It had never been severe enough that he had ever been to a doctor about it or told his parents about it, but he did note that after the diagnosis. So the primary care doctor promptly got him into an adult endocrinologist who got a hemoglobin A1C that was greater than 14, which was the max that lab would go up to, and did some workup and quickly confirmed the diagnosis of type 1 diabetes. The endocrinologist promptly got him on a basal bolus regimen and got him a continuous glucose monitor and quickly got his diabetes right to where everyone's goal was. Fasting sugars, postprandial sugars, everything was exactly where the endocrinologist wanted him to be. So the patient did really good on treatment. He started gaining weight back that he hadn't been able to gain before, and had actually been losing a little bit of weight before the diagnosis. He was feeling good on the insulin, and good start to this diagnosis. But less than 4 weeks into treatment with the insulin regimen, he started having severe pain. The pain started in his scrotum and groin, and then eventually moved down into his legs and concentrated into his feet. And talking with the patient 2 years after this happened, I just asked him to describe the pain for me. And without hesitation, 10 out of 10 pain, worst pain I've ever experienced. Felt like someone was stabbing my feet with a knife. And then his mom just said for 2 months, he didn't sleep at all. And she would stay up at nights holding him like a big 18-year-old baby because he was in so much pain. He talked to both of his providers at this time for these symptoms. His primary care doctor was pretty empathetic, said, maybe it's neuropathy, but you've only had diabetes for 2 months, a month. Doesn't seem really consistent, but tried to give him some gabapentin and some topical medicines, some capsaicin and some lidocaine. He also went to his endocrinologist and told him about this severe pain he was having, and the endocrinologist was not as empathetic. Said, I'm an endocrinologist, I treat diabetes. These symptoms are not related to your diabetes, and kind of dismissed him, which was unfortunate. So about 2 months into this terrible, terrible pain that he was having, he started developing a bunch of GI symptoms and also some orthostatic intolerance. This is when me and my senior resident met the patient. He came into our hospital and we got assigned to take care of him. And his nausea and vomiting were so refractory to any of the medications that we were trying to give him. We got a GI consult and they did a gastric emptying study, and he was diagnosed with gastroparesis. He was up to 138 pounds with the insulin treatment, but because of this severe nausea and vomiting, he got down to 97 pounds. And this is a picture of him close to when he was at his lowest weight. The gastroenterology team wanted to put in an enteral feeding tube, and he just refused. And thankfully, he recovered from this. So over the next 7 months, we treated him in our clinic symptomatically. We gave him medicines for the pain, medicines for the nausea and the vomiting, and tried to help him with his orthostatic intolerance. And thankfully, he made a full recovery about 7 months after his initial pain started. So what is treatment-induced neuropathy of diabetes and what causes it? It was first described about 100 years ago. A physician had a patient with diabetes. He would put her on insulin and she would get this terrible neuropathic pain. And then he would take the insulin off and let her diabetes get out of control and the pain would go away. And that was reproducible with this patient. So there was a group that took a lot of interest in this, and they've done the largest study on this with a cohort of 100 patients, and they came up with diagnostic criteria. So the diagnostic criteria is a rapid correction in hemoglobin A1C, at least 2% over 3 months. But like I say, but there's a strong correlation between how much the hemoglobin A1C drop is and how fast it is with the chance of getting this condition and the severity of the condition. So you have to have that rapid drop in A1C along with a severe neuropathy and autonomic symptoms that are temporarily related to when the drop in A1C is. Can happen in any type of diabetes and can be from anything that helps you get rapid control of the diabetes. So insulin, other oral drugs, or even a severe or marked diet change that causes a rapid drop in A1C can cause this. The exact cause for this condition is unknown, but there are many theories, but nothing has been proven yet. And cases, it's not an extremely well-known condition. The endocrinologist didn't think about it. The new endocrinologist that this patient ended up seeing had never heard of this condition either. So rapid reduction in A1C, and then rapid symptoms of severe neuropathy and or autonomic symptoms. Thankfully, most of the time in type 1 diabetics, it is reversible. And people usually get feeling at least some percent better after 12 to 18 months. This patient had a more rapid course than most of the patients that have been studied. So the question is could this diagnosis, or the knowledge of this diagnosis, could this be practice changing, and should it be practice changing? And this patient and his family say yes. It was the one thing I asked him a couple days ago when I told him I was presenting. I said, what do you want me to let people know about this condition? And he just said, just tell them that, do we really need to lower A1Cs that quickly? And I think we have ample data that shows that getting an A1C, getting glycemic control in the long run is extremely important and leads to way better outcomes. But I think it's something to think about. Do we really need to get glycemic control in the first month, or in the first 2 months, or in the first 3 months? Or can we have a goal to get them more slowly to where they need to be, and then keep them at that position? It was a very interesting case. Like I said, one of the most impactful that I've had, and hope you guys enjoy it, and happy to answer any questions for you guys.